The house is completely silent. It's 3:17 in the morning. You know that without even looking at the clock. Because this has been happening long enough that your body has its own alarm. You're lying there, ceiling above you, the kind of dark that should feel peaceful. But something pulled you out. Not a sound, not a dream you can remember. Just awake. Suddenly, completely, frustratingly awake. Your mind starts moving before you can stop it. The list, the worry. The thing you said in 2009. Why is the heating making that noise? You try to drift back. An hour passes, maybe two. And in the morning, you feel it, that low, heavy tiredness that coffee doesn't quite fix, that feeling of carrying something you can't name. Here's what I want you to understand before we go any further. This isn't just getting older. This isn't your body winding down. This is your body trying to hand you a very specific warning note, and most people never read it. I'm Dr. Qalb, and this channel exists for one reason, to give you the real science behind what your body is doing, without the fear, without the hype, and without the clickbait designed to keep you anxious and clicking. We don't do that here. What we do is connect the dots between a symptom like waking at 3 a.m. and the bigger picture hiding underneath, because the picture is almost always more specific and more fixable than you've been told. Before we get into this, hit subscribe because next week we're covering something that genuinely shocked me when I reviewed the data. The specific blood marker that predicts cognitive decline up to 6 years before any symptoms appear, and why almost no one is testing for it at their annual checkup. I'll give you the name of the test and exactly what to ask your doctor. But right now, waking up between 2 and 4 a.m. every single night. Let's talk about what's really going on. Most people treat middle of the night waking as a sleep problem. It isn't, not exactly. According to research published in the journal Sleep Medicine Reviews, non restorative sleep, the kind where you wake in the night and can't return, affects somewhere between 30 and 40% of adults over 60. But here's the buried insight inside that number. In the majority of cases, the waking itself is a symptom, not a diagnosis. The sleep is not broken, something else is, and the sleep is simply announcing it. Think of it like a smoke detector. When the alarm sounds, you don't fix the alarm, you look for the fire. That 2 a.m. waking, the consistent, patterned, predictable middle of the night arousal, is your smoke detector. And over the next few minutes, I'm going to walk you through the five primary causes I see behind it in adults over 60. There are five primary causes I want to walk you through, and I'll tell you right now, at least one of them is probably going to make you stop and think. Cause 1: Cortisol dysregulation, Part A. Most people assume middle of the night waking is about the mind. Stress, anxiety, I'm a worrier. And while the mind plays a role, the mechanism is almost always biochemical, specifically a hormone called cortisol. Cortisol is your body's primary stress hormone. But here's what most people don't know: cortisol is also your primary wake hormone. It's supposed to rise gradually in the early morning hours, typically spiking around 6 or 7 a.m., to prepare your body for the day. In many adults over 60, that curve shifts. The spike happens earlier, much earlier. And when cortisol rises at 2 or 3 a.m., your body responds exactly the way it's designed to. It wakes up. The worry and racing thoughts you experience, they are not causing the waking. They are a side effect of it. The cortisol came first. Part B, a study from the National Institute on Aging followed cortisol patterns in adults over 65 and found that dysregulated cortisol rhythms, meaning cortisol peaking at the wrong time, were significantly more common in this group than in younger cohorts. The surface finding is that stress affects sleep. Most people hear that and nod. The buried insight is more specific. The pattern wasn't linked to how stressed participants reported feeling. It was linked to lifestyle and physiological factors: blood sugar instability, chronic low grade inflammation, and disrupted light exposure, things that are entirely addressable. People with normal reported stress levels were experiencing the same cortisol shift, which means just relax is not the answer, and it never was. Part C, Patient Story. Margaret, 67, a retired school librarian from Ohio, came to me exhausted. She was waking every single night between 2:30 and 3 a.m. No alarm, no noise, no obvious reason. She described lying there for 2 hours minimum, mind spinning, before finally drifting off, only to have her actual alarm drag her out of the shallow end of sleep at 6:30. She'd cut caffeine, she'd tried melatonin, she'd started reading before bed. What we discovered was that Margaret was eating dinner late, around 8:30 p.m., and having a small glass of juice with it. That late evening sugar spike was triggering a corresponding dip in blood glucose in the early morning hours, and that dip was activating her stress response. Cortisol was rising to compensate. She moved dinner to 6:30, cut the juice, and added a small protein snack before bed, a handful of walnuts and a slice of cheese. Within 10 days, the 3 a.m. waking had reduced from 7 nights a week to 1 or 2. Part D. This week, audit your last meal of the day. If you're eating after 7:30 p.m., and especially if that meal includes refined carbohydrates, fruit juice, or sugar, experiment with shifting dinner earlier by 60 to 90 minutes. Add a small protein and fat snack about an hour before bed. Greek yogurt, a small handful of nuts, a piece of cheese. Not a meal, just enough to stabilize blood sugar through the night. Give it 7 days and track what happens. This is one of the most underrated interventions in sleep medicine and it costs nothing. Cause 2, Sleep Disordered Breathing Part A. When most people think about sleep apnea, they picture loud snoring and a CPAP machine. They picture someone else. Here's what I want to challenge. The most common form of sleep disordered breathing that causes middle of the night waking in older adults doesn't always involve loud snoring. It doesn't always wake your partner. It doesn't always feel like gasping. It can present as quiet, shallow breathing, brief pauses that your body detects at a subconscious level, followed by a micro arousal that pulls you just close enough to wakefulness that you fully surface. By the time you're awake at 3 a.m., you don't know why. You have no memory of struggling to breathe. Part B. The American Academy of Sleep Medicine estimates that sleep disordered breathing affects over 50% of adults over 65, and that more than 80% of moderate to severe cases remain undiagnosed. The surface stat is alarming enough, majority undiagnosed. But the buried insight is this: in older adults, the most common symptom reported is not snoring or daytime sleepiness. It's middle of the night waking. That's the presenting complaint, which means millions of people are treating insomnia when what they actually have is a breathing issue that can be screened for with a test you can do at home. Part C, Patient Story. Robert, 71, a former engineer from North Carolina, was convinced he slept fine. His wife had passed 2 years earlier, so there was no one to report snoring. He woke each night around 2:45 a.m., read for an hour, went back to sleep. He called it just how it is now. What concerned me was his blood pressure, stubbornly elevated despite medication, and his report of waking with a dry mouth and mild headache several mornings a week. These are classic signs that the brain has been working hard overnight, deprived of adequate oxygen. We referred him for a home sleep study. It came back with a significant number of breathing events per hour. With treatment, Robert's morning headaches disappeared within a week. His nighttime waking dropped dramatically, and at his next cardiology follow up, his blood pressure readings were the best they'd been in 3 years. Part D. Ask yourself three questions. Do you wake with a dry mouth? Do you sometimes have a dull headache in the morning? Has anyone ever mentioned that your breathing sounds irregular at night? If you answered yes to even one of those, bring it to your doctor at your next visit and use this exact phrase: I'd like to be screened for sleep disordered breathing. Home sleep tests are widely available, often covered by insurance, and done entirely in the comfort of your own bed. This is one of the highest yield conversations you can have with your physician. If you're still here and finding this helpful, type the number 3 in the comments. It helps me know this content is reaching the people who need it. Cause 3, Declining Melatonin Production Part A. You've probably heard of melatonin, the sleep hormone, and you may have even tried it as a supplement. But here's what the supplement aisle doesn't tell you. Melatonin production in the brain begins declining in your late 40s and continues falling steadily through your 60s, 70s, and beyond. By the time many people reach 70, their natural melatonin output at night may be less than one quarter of what it was at 30. And the more important story isn't just total melatonin, it's timing. Melatonin doesn't just help you fall asleep, it helps you stay in the deeper, more restorative stages of sleep during the second half of the night. When melatonin falls off too early, which is exactly what happens with age related decline, the back half of your night becomes lighter, more fragmented, and far easier to interrupt. That 2 to 4 a.m. window, that's the back half of the night. That is when melatonin's role is most critical. Part B. Research published in the Journal of Pineal Research found that by age 70, the nighttime peak of melatonin is significantly reduced compared to younger adults, and in some individuals, it is almost undetectable. The surface finding: melatonin goes down as we age. The buried insight: the decline is not inevitable in the sense that it cannot be influenced. Light exposure is the single biggest driver of melatonin production, and modern indoor life, bright overhead lighting in the evenings, screen exposure before bed, and insufficient morning sunlight actively accelerates the decline. Your lifestyle may be compressing your melatonin window more than age alone. Part C. Patient Story. Carol, 69, a retired nurse from Oregon, told me she felt like her body simply forgot how to sleep past 3 a.m. She'd taken melatonin supplements before, the standard 5 milligram dose you see on most shelves, and reported they made her feel groggy in the morning without helping her stay asleep. We made two changes. First, we shifted her evening light environment: warm tone lamps after 7 pm, no overhead fluorescent lights, phone in night mode after 8. Second, we worked on her morning routine: 10 minutes outside in natural light within the first 30 minutes of waking, regardless of weather. Within 3 weeks, Carol noticed she was waking at 3 a.m. less often. Within 6 weeks, she described sleeping through to 5 or 5:30 a.m. several nights a week, something she hadn't done in years. She hadn't changed her supplement, she'd changed her light. Part D. Two things starting tonight. After 7 pm, switch to warm, low intensity lighting. If you have smart bulbs, drop them to 2700 Kelvin or lower. If you don't, try a simple salt lamp or warm toned floor lamp. Turn off overhead lights. Tomorrow morning, go outside within 30 minutes of waking. Even 5 minutes in natural light, overcast counts, sends a powerful signal to your brain's internal clock that day has started, which in turn helps calibrate when your melatonin cycle begins that evening. It sounds almost too simple. The research says it isn't. Cause 4: blood pressure and cardiovascular nocturnal patterns. Part A. This one doesn't get talked about enough, and I think it should. Most people know their blood pressure during the day. Very few people know what their blood pressure does at night. And here is something your cardiologist may not have explained to you directly. In a healthy cardiovascular system, blood pressure dips during sleep, typically by 10 to 20%. Doctors call this dipping. In a significant portion of adults over 60, this dip doesn't happen. Blood pressure stays elevated or even rises during the night. This is called non dipping or reverse dipping, and it is associated with an increased burden on the heart and brain during the very hours when the body is supposed to be resting and repairing. And one of its most consistent symptoms is waking in the early morning hours, feeling alert, sometimes slightly agitated, with no clear reason why. Part B. A large study published in Hypertension, the Journal of the American Heart Association, found that non dipping blood pressure patterns are present in 30 to 40% of hypertensive adults, and that they are significantly associated with higher risk of cardiovascular events, independent of average daytime blood pressure readings. The surface stat: nighttime blood pressure matters. The buried insight: most blood pressure management in primary care is based entirely on daytime readings. Your morning clinic measurement tells your doctor almost nothing about what your blood pressure is doing at 3 a.m. You could have a perfectly normal daytime reading and a serious nocturnal elevation pattern, and it would never show up in a routine checkup. This is a surveillance gap hiding in plain sight. Part C, Patient Story. Gerald, 73, a retired postal worker from Michigan, had been on blood pressure medication for 11 years. His daytime readings were well controlled. His doctor was happy, he was happy. But he was waking between 3 and 4 a.m. nearly every night, feeling alert and faintly restless. No chest pain, no obvious distress, just awake. On my recommendation, Gerald asked his doctor about ambulatory blood pressure monitoring, a small device worn for 24 hours that records readings throughout the day and night. The results showed his nighttime blood pressure was considerably higher than his daytime numbers. A non dipping pattern, clear as day. His medication timing was adjusted. One of his medications moved to an evening dose rather than morning. Within a month, Gerald's nighttime readings normalized, and he began sleeping through the night more consistently than he had in years. Part D. If you are on blood pressure medication and you consistently wake between 2 and 4 a.m., ask your doctor at your very next appointment about ambulatory blood pressure monitoring or ABPM. Use these words: I've been waking consistently at night and I'd like to know what my blood pressure is doing while I sleep. This is a recognized, covered medical test. It is not exotic or unusual, and it has changed the treatment course for many patients whose nighttime readings were simply never being measured. Important safety note: do not adjust blood pressure medication timing on your own. This must be done with your physician's guidance. Cause 5: Anxiety, rumination, and the hyperarousal loop. Part A. I saved this one for last, not because it's least important, it may be the most common, but because I wanted to give it the context it deserves after everything we've discussed. Because here's the truth about anxiety and night waking: most people have it backwards. They believe anxiety causes the waking. Wake up, mind races, anxiety rises, can't sleep. Linear, simple. The reality is more circular. Yes, underlying anxiety and stress lower the threshold for waking. But the waking itself, once it happens repeatedly, begins to create its own anxiety. Your brain learns that 3 a.m. means alertness. It begins anticipating it. The bed begins to feel like a place of frustration rather than rest. Researchers call this hyperarousal, and it becomes its own self sustaining loop, entirely separate from whatever originally started the waking. You can resolve every other cause on this list and still struggle if the hyperarousal loop has been running for years. Part B. The Journal of Clinical Sleep Medicine published research showing that hyperarousal, measurable as heightened brain activity and elevated core body temperature during sleep, is one of the most reliable predictors of chronic insomnia in older adults. Surface finding: anxious people sleep worse. Buried insight: hyperarousal is not a personality trait, it is a learned physiological pattern, and the gold standard treatment for it, cognitive behavioral therapy for insomnia, or CBTI, has been shown in multiple studies to outperform sleep medication for long term outcomes. Not match it, outperform it. And it has no side effects. Part C, Patient Story. Dorothy, 74, a retired bookkeeper from Georgia, had been waking at 2:45 a.m. for 4 years. By the time she came to see me, she had developed a precise ritual around the waking. She would check the clock, calculate how many hours she had left, feel a wave of frustration, get up, sit in her armchair, and try to read until she felt tired enough to return. She described the armchair as her 3 a.m. chair. That chair was part of the problem. What Dorothy had developed, unknowingly, innocently, was a set of behaviors that were teaching her brain that night waking was normal, expected, and required a specific response. Every time she got up, she reinforced the pattern. Working with a sleep specialist trained in CBT1, Dorothy gradually restructured her response to waking. The process was not fast, it took about 6 weeks, but the results were durable. The waking didn't disappear immediately, but her relationship to it changed. The anxiety around it dissolved first, then the frequency followed. Part D. Search for a CBTI practitioner in your area. Your primary care doctor can refer you, or you can look for certified therapists through the Society of Behavioral Sleep Medicine's directory online. If in person access is limited, several digitally delivered CBTI programs have strong clinical evidence behind them. Ask your doctor or look for programs affiliated with university sleep centers. One immediate thing you can do tonight: if you wake and cannot sleep after 20 minutes, get up. But go to a different room, keep the lights low, and do something quiet and non stimulating until you feel genuinely sleepy. Do not lie in bed awake watching the clock. That is how the hyperarousal loop gets fed. Action plan, your 5 step roadmap. Let's bring this together. Step 1: Audit your last meal. Move dinner earlier if possible, ideally by 7 p.m., and add a small protein fat snack before bed to stabilize overnight blood sugar. Step 2: Ask your doctor about a sleep disordered breathing screening, especially if you wake with dry mouth, morning headache, or elevated blood pressure. Use the words, "I'd like to be screened." Step 3: Restructure your evening light. Warm, low lighting after 7 p.m. 10 minutes of natural morning light within 30 minutes of waking. Do both consistently for 2 weeks before judging the result. Step 4: If you are on blood pressure medication, request ambulatory blood pressure monitoring at your next appointment. Ask specifically about your nighttime readings and whether your medication timing has been reviewed. Step 5: If you have been waking for more than 3 months and recognize the hyperarousal pattern, the clock watching, the frustration, the learned anticipation, ask for a referral to a CBTI specialist. This is a medical treatment. You are entitled to ask for it. Safety notes: if you take blood thinners, blood pressure medication, or medications for heart rhythm, do not change any timing or dosage without explicit guidance from your physician. If your night waking is accompanied by chest tightness, shortness of breath, severe headache, or confusion, do not wait. Seek medical attention promptly. These combinations warrant same day evaluation. Here is what I want you to carry with you from today. Waking up between 2 and 4 a.m. every night is common. I want to be very clear. Common is not the same as normal, and it is absolutely not the same as harmless. Your body is doing something specific, something measurable, something that in many cases is directly addressable if someone takes the time to look. You now have 5 places to look. I'd like to ask you something in the comments. Of the 5 causes we covered today, which one landed for you? Type cortisol if the blood sugar and evening eating resonated. Type breathing if the sleep apnea discussion felt like it might be describing you. Type light if the melatonin section was the surprise. Your answer helps me understand what this community needs most, and it might help someone else reading the comments recognize themselves. Next week, we are going back to the blood work conversation, specifically the one marker your annual panel almost certainly isn't checking that has emerged in the research as an early predictor of cognitive change. I'll name the test, explain what the number means, and tell you exactly how to bring it up with your doctor. Subscribe so you don't miss it. I'm Dr. Qalb. Take good care of yourself this week. You've already taken one important step by being here. Share this with someone you care about. You might do them more good than you know.